Dr. Shonali Chandra, and I welcome you all to our YouTube channel, Medicine Decoded. Now, I received requests from you people to talk about thromboprophylaxis in pregnancy. This needed a little bit of reading to do. So I agree it took me a while, but now I'll try to do justice to this huge topic. Now, talking from my perspective as well as from students' perspective, I realized that we find this topic a little daunting, a little confusing, a little difficult at times, and simply because there's so many international guidelines in place, and these are all consensus guidelines, they are well-reputed guidelines. And we also need to keep in mind that, under different clinical setups, institutions, in different countries, people may be following different guidelines, which is all fine, right? So please stick to your institutional guidelines as well while dealing with thromboprophylaxis in pregnancy. Now, these guidelines, various international guidelines, they are similar in some respects, they differ in opinions sometimes, but the basic fundamentals regarding thromboprophylaxis in pregnancy are quite similar. So what I feel as primary healthcare providers we need to be aware of is one fact that pregnancy is a situation where the risk for thrombosis increases. So we as primary healthcare providers need to be aware of the different, maybe obstetric, maybe non-obstetric risk factors which will further increase this risk of thrombosis. So we need to be aware of which are the set of women who definitely deserve thromboprophylaxis in pregnancy. So we are the first contact of these pregnant women. If we are not aware of those risk factors, how are we going to refer these women to hematologists or specialists who deal particularly with thromboprophylaxis in pregnancy? So with that goal in mind, that I should not miss out on the risk factors, I'll talk about thromboprophylaxis in pregnancy in this video. And first I'll talk about how common is it, what is the incidence of venous thrombosis in pregnancy. So if you compare pregnant versus non-pregnant women, right? So during pregnancy, the risk of thrombosis is about 5 times more, okay, if you compare pregnant versus non-pregnant women. But that might look like a lot, 5 times, but if you convert this 5 times into absolute risk, in absolute numbers, then the incidence of deep venous thrombosis is about 1 in 1,000 pregnancies. And the incidence of pulmonary embolism is about 1 in 7,000 pregnancies. Having said that, you need to be aware of why pregnancy is a thrombogenic state, right? So look at this Vercoe's triad here, and you realize, as we'll go through, that all of these factors at some level operate in pregnancy and in the immediate postpartum period. Like, for example, yes, hypercoagulability. Pregnancy is a hypercoagulable state. Well, the high amounts of estrogen that is circulating in the bloodstream during pregnancy coming from the placenta increases the clotting factors. So all clotting factors are increased in pregnancy except for factor 11 and 13. So that causes a hypercoagulable state. Secondly, stasis also operates during pregnancy. So you see that you have this gravid uterus, right? And this gravid uterus can cause compression over the iliac veins, right? And when it causes compression over the iliac veins, there is decreased venous return from the lower limb upwards, right? So what we realize that there is stasis in the iliofemoral circulation, right? So stasis is also occurring during a pregnancy. More so, there can be other incidences which can favor stasis as well. Like, for example, pregnancy associated complications like hyperemesis, right? That leads to dehydration, or dehydration because of other reasons, or hypovolemia, right, in the face of postpartum hemorrhage, right? They all are going to favor stasis. Gravid uterus putting compression, of course, is favoring stasis. So stasis also operates. So a woman with hyperemesis, a woman with hypovolemia, shock in the face of antepartum hemorrhage and postpartum hemorrhage becomes high risk for thrombosis as well. Now, let's talk about endothelial injury. That also operates in pregnancy. Now, delivery itself, the process of delivery itself can also trigger endothelial injury in the pelvic circulation, right? And other than that, obstetric complications like preeclampsia, pregnancy in a woman with chronic hypertension, placental abruption, or infection for that matter, which triggers endothelial injury, severe puerperal infection after delivery. All of these events have potential to cause endothelial injury. So pregnancy in itself can have increased risk of thrombosis because all of these reasons, and this helps us understand the various risk factors in pregnant women which are associated with increased risk of thrombosis. Now, considering pregnancy and thrombosis, outside of pregnancy, you see there is a predilection for deep venous thrombosis in the calf veins. But in pregnancy, thrombosis is more commonly encountered in the iliofemoral veins. And that too more commonly on the left side, because it is on the left side that the left iliac vein in addition is also compressed by the left iliac artery and the left ovarian vein on the left side particularly. That's why more common on the left side. And there is more risk of thrombosis after a cesarean delivery as compared to a vaginal delivery, because post cesarean section, the return of mobilization, ambulatory status, walking and everything will take a little bit of more time as compared to vaginal delivery. By the same logic, you see the risk of thrombosis is also more when instrumental vaginal delivery has been performed. And please also remember that the risk of thrombosis also persists in the puerperal period, in the postpartum period, because it takes some time for the clotting factors to return to normal. It takes about 6 weeks at least, for the clotting factors to come back to normal post delivery. So the risks of thrombosis, they persist throughout pregnancy as well as in the puerperal period. That is why it is always very, very important to ask the pregnant women, to keep their hydration up, maintain their hydration, maintain their mobility. Even after delivery, it is very important that the woman is up and about and moving around. Even after cesarean section, if she's not particularly sick, she should be allowed for early mobilization and ambulation. And if that cannot be done, prevention for thrombosis should be put in place with the help of, elastic compression stockings that should be put in place if the woman is not able to walk around. Now, also in my previous video, I discussed how inherited thrombophilias increase the risk of thrombosis. There can be prothrombin gene mutation, there can be factor V Leiden mutation, there can be antithrombin 3 deficiency, antithrombin 3 deficiency being the most thrombogenic of all thrombophilias. So there can be a variety of inherited thrombophilias which increase the risk even further. But how would we recognize such women? So if there is a personal history of past event of deep venous thrombosis or venous thromboembolism, and if there is a family history of DVT or venous thromboembolism in a first degree relative, that is parent or sibling, and especially so if the family history happened to be in an individual who had been less than 50 years of age. Now, if this is the kind of history that you find, then that woman, that pregnant woman, should be subjected to thrombophilia screening. Okay, and inherited thrombophilia screening. And it becomes easier when you know exactly which thrombophilia had affected the relative. So you need to be aware of that as well. Now, moving on, there can also be acquired thrombophilias like antiphospholipid antibody syndrome. This antiphospholipid antibody syndrome can also be associated with systemic lupus erythematosus. Now, this antiphospholipid antibody syndrome has been seen to cause arterial or venous thrombosis. It can also, cause recurrent pregnancy losses. So apart from thrombosis, they can also lead to adverse obstetric outcomes, right? So recurrent pregnancy losses, because you see these antiphospholipid antibodies, they also target the syncytial trophoblasts in the developing placenta, because these phospholipid antibodies are targeting the phospholipids in the cell membrane. So they target the syncytial trophoblast also. They can also target the platelets. So they can lead to recurrent pregnancy losses. They can, target the placental circulation, can cause thrombosis in the placental circulation, and lead to risk of preeclampsia, early onset preeclampsia, particularly early onset intrauterine growth retardation, and even stillbirth risk. So antiphospholipid antibody syndrome can be associated with other pregnancy related complications as well. So particularly if there is a woman with a history of recurrent pregnancy losses, maybe arterial venous thrombosis history is there, or there is history of early onset preeclampsia, unexplained IUGR in previous pregnancy, unexplained stillbirth in previous pregnancy, particularly if that happened before 34 weeks of gestation in the prior pregnancy, they deserve testing for antiphospholipid antibody syndrome as well. So if there is such high risk history, make sure that you are offering antiphospholipid antibody testing also to these set of women. So yes, pregnancy is a condition where the risk of venous thrombosis increases, but not all women who are pregnant will need thromboprophylaxis. So who are those women who need thromboprophylaxis during pregnancy and the postpartum period? Important key is that you should know the risk factors, right? And the most important risk factor is history of prior venous thromboembolic event. When that happens, you start thinking maybe she has inherited thrombophilia or acquired thrombophilia. This gives a very, very high risk of thrombosis in pregnancy. Also, I want to highlight at this point in time that fresh risk factors can arise during the course of pregnancy. Right? Like for example, a woman could go on to develop severe preeclampsia, and she might be also be obese at the same time. She might also be having a heart disease at the same time. So additional risk factors could arise during the course of 9 months of pregnancy. Or let's say, for example, there's an obese woman who underwent a cesarean section, and then that also got complicated. Then she had sepsis, or maybe prolonged recovery time. She was bedridden for a long duration. So now fresh factors are appearing at each step, right? Putting her at increased risk of thrombosis. That is why at every step you need to be aware of the risk factors when you have to consider the need for thromboprophylaxis, right? So at each time you need to evaluate the woman. Like now let's say if there is any prior history of venous thromboembolism in a woman, and you've eliminated that it was not due to a major surgical event. That means if there is a history of prior thromboembolism and that episode was, let's say, unprovoked, it was not like she was undergoing a major surgical event at that point in time. If that is the kind of history, then this is considered very high risk situation, and this woman needs thromboprophylaxis throughout pregnancy. Okay, this woman needs thromboprophylaxis throughout her pregnancy, starting from the first trimester itself, right? And also continuing for 6 weeks postpartum. Okay. Now, let's say if there is a situation where there has been thrombosis in the past due to a major surgery, or let's say she's currently pregnant and she's undergoing a major surgery procedure during pregnancy, which will require her to stay in the hospital and be bedridden, undergoing a prolonged surgery now during pregnancy. Or let's say she had a family history of thrombophilic episode, venous thromboembolism. So we tested her. We found that she herself is having a high risk inheritable thrombophilia, but no prior personal history of venous thromboembolism is there. Or let's say she's currently pregnant, underwent IVF, and now is having ovarian hyperstimulation syndrome, or she's the woman pregnant with additional medical comorbidities like cancer, heart failure, sickle cell disease, or active SLE. These are just some common examples I've given. There is another whole list of medical comorbidities which can be there. Now, these are situations where you are going to consider the medicine shot. That means you are going to consider thromboprophylaxis. Okay, so be aware of these risk factors as well. Okay, so this is just a mnemonic standing for considering that thromboprophylaxis may be required, medicine for medical comorbidities, SHOT, a prolonged surgery, right, high risk thrombophilias even without any history of prior thromboembolism, OHSS, and thrombosis in the past, which was due to a major surgery, right? Now, there is also this long list of risk factors, okay, which is given in the international guidelines. I'm quoting from the Royal College of Obstetrics and Gynecologists, RCOG guidelines. So yes, let us devise a quick mnemonic to remember them by. It's not so necessary to be aware of, to mug them up in sequence, but it would be wise to be aware of these risk factors at least. So the mnemonic stands for in pregnancy, variable antenatal factors often indicate low molecular heparin prophylaxis, right? So that sentence in itself is a mnemonic for the risk factors: immobility, multiparity, varicose veins which are grossly visible, age more than 35, family history of venous thromboembolism, smoker, obesity, IVF conception, low risk thrombophilias, right? Multiple pregnancy, hypertension, preeclampsia. So you need to be aware of the list of these risk factors also. Now, if there are 4 or more than 4 risk factors in the woman at any point in time, right? 4 or more than 4 risk factors, then prophylaxis is needed from the first trimester onwards. So that will make it high risk, very high risk, right? And if only 3 factors are present of the entire list, then she will need prophylaxis from 28 weeks onwards. And if less than 3 factors are present, then she doesn't need, drug prophylaxis, but she will need other measures like, you will have to counsel her regarding the need to keep herself mobilized, to walk around daily basis and to maintain hydration. I mean, this has to be anyways emphasized in pregnant women, but in these set of women it has to be particularly stringently emphasized that they should not be bedridden, they should be up and about, and they should be maintaining their hydration. Okay, now moving on further, let's talk about the need for prophylaxis in the postpartum period. Now, like I discussed in the very beginning, that if there is a history of previous venous thromboembolism, she needs prophylaxis during the 9 months of pregnancy as well as for 6 weeks postpartum. If a woman has received antenatal heparin, based on the combination of risk factors here, she will likely need a prophylaxis in the immediate postpartum period also. If she has a high risk thrombophilia, even without a history of thrombosis in the past, she will need prophylaxis in the postpartum period. And if she has a low risk thrombophilia plus a family history, she will require prophylaxis in the postpartum period. So these are definite indications for need of prophylaxis in the postpartum period. Now, like I said again, fresh risk factors can arise in the postpartum period as well, and then also the need for postpartum prophylaxis should be considered. Sometimes there are intermediate risk factors, then only 10 days of prophylaxis is given. At other times, when there are multiple risk factors and it falls under high risk category, maybe 6 weeks of prophylaxis is required. Now that makes this whole topic very huge to understand, but yes, I hope that you are understanding the very basics that you need to keep in mind these particular risk factors. All right. Now, moving on further, let's talk about what is the drug of choice for thromboprophylaxis. Now, we have the choice between heparin and warfarin. Now, warfarin is also an anticoagulant and heparin is also an anticoagulant. Now, warfarin is really not considered the drug of choice because obviously it can cross the placenta. It can be used, if used in the first trimester, it will be teratogenic to the fetus. If continued use in the second trimester, it can also lead to growth retardation of the baby, right? So yes, heparin is the drug of choice, not warfarin. Okay. Now, if you consider heparin, we have two options. We have unfractionated heparin and low molecular weight heparin. Now, heparin does not cross the placenta in any significant amount, so it is safe to use in pregnancy. Now, with unfractionated heparin, disadvantage is that the side effects are more. The side effects like the risk of bleeding, the side effects like the risk of heparin-induced thrombocytopenia, the side effects like the development of osteoporosis, they are more with unfractionated heparin as compared to low molecular weight heparin. The advantage is that it is cheaper. The other reason why low molecular weight heparin is preferred and is the drug of choice is because of better bioavailability. It has a longer half-life, so less frequent dosing is required. So when you consider the prophylactic dosages, then low molecular weight heparin can be used as once daily dosing as well, and yes, lesser side effects. So these are all advantages of low molecular weight heparin, like enoxaparin and dalteparin. But then again, the restriction is that they are costlier as compared to unfractionated heparin. So the drug of choice for thromboprophylaxis is heparin, right? And preference is given to low molecular weight heparin. Now, moving on, during labor and delivery, if we have started a woman on antenatal thromboprophylaxis, then during labor and delivery, that thromboprophylaxis need to stop, right? So we need to stop the heparin. Why is that? The concern is, of course, if we are giving anticoagulation, even if it is a prophylactic anticoagulation, the concern is that there can be an increased risk of bleeding during delivery, right, like PPH. And the other concern is that if during the course of her delivery she requests epidural analgesia, or she undergoes a cesarean section under epidural anesthesia or spinal anesthesia for that matter. So with regional analgesia and anesthesia techniques, you see, there can be a risk of hematomas there. So these are very valid concerns during the time of delivery, for which one should stop heparin. Now, stopping heparin, now we have to also consider that we are dealing with the risk of thrombosis vis-a-vis the risk of bleeding, right? So many people, many guidelines recommend that, and these are consensus guidelines, that during the last month of pregnancy, if you have this opportunity, then in the last month of pregnancy, if the woman is on low molecular weight heparin, before that she should be switched over to unfractionated heparin. Now, why is that? The reason for this is that unfractionated heparin has a shorter half-life. Okay, right? That means when I stop it, if I stop the injection of unfractionated heparin, then another 12 hours and the effect goes away. Okay, so let's say that a woman was switched over to unfractionated heparin in the last month of pregnancy. Okay, now in the last month, she can go into labor anytime now. Then I have that window of opportunity. You see, I stop it as and when she goes into labor, and within 12 hours, the effect goes away. Moreover, you see, monitoring with unfractionated heparin is easier. The effect of unfractionated heparin can be monitored by measuring the APTT values. Okay, so monitoring becomes easier, and if at all you have to reverse the effect of anticoagulation, then an antidote in the form of protamine sulfate is available, right? So this is a wise choice actually, to switch over from low molecular weight heparin to unfractionated heparin in the last month of pregnancy. Okay. Now moving on further, let's have a look at certain case scenarios. Now let's say there is a pregnant woman and she is on low molecular weight heparin, and she has to be scheduled for an elective cesarean section or induction of labor. Let's say that you were maybe not able to switch her off to unfractionated heparin, and now she's already on low molecular weight heparin. You have to schedule her for elective cesarean section or induction of labor. Make sure that you give at least a 24 hours of time gap between the last dose of low molecular weight heparin and the scheduled induction or elective cesarean section. So make sure that you stop low molecular weight heparin preferably 24 hours prior. So with scheduled events, it becomes easier. Okay, with scheduled events, it becomes easier. That means you can give the dose today, and if I'm scheduling the induction or the elective cesarean section tomorrow, then I don't give the morning dose tomorrow. Like the morning dose on the day of the scheduled event will not be given. So with scheduled events, it becomes easier. However, if a woman is on low molecular weight heparin and she happens to go into spontaneous labor, then any further dosages of low molecular weight heparin should not be given during the course of labor. Now, let's say, for example, there is a pregnant woman who is on thromboprophylaxis. Like I said, she went into labor, into spontaneous labor. You stopped any further dosages. You stopped further dosages. And now she requires regional analgesia. Okay, then you have to make sure that enough time has elapsed or enough time has passed since stopping heparin. And how much is that time? That is important. So if she is on prophylactic dose of low molecular weight heparin, it is advisable that at least 12 hours have passed. And if she is on therapeutic, which are higher dosages, therapeutic dosages of low molecular weight heparin, then it is advised that at least 24 hours have passed since stopping heparin, right? Only then you should be starting or requesting to start regional analgesia. At every point in time, please remember, care of such women needs to take into the discretion of the consultant obstetrician, the high risk medicine person in charge, and also the anesthetist and hematologist in charge. So ideally, yes, multidisciplinary care should be used for such women. Okay. Now, moving on further, let's say this woman delivered. Okay, now she was on low molecular weight heparin therapy before delivery, which was stopped during delivery. Now, the next question arises is how soon to start heparin after delivery, right? So one thing that you need to keep in mind here is that if there has not been any regional analgesia used, and if there is no postpartum hemorrhage or no immediate risk factors arising in the postpartum period, nothing fresh, no fresh risk factors, then one can start heparin after delivery soon enough, but not before 4 hours post delivery. Okay, and under those circumstances, you see a reasonable time frame. What should be a reasonable time frame? A reasonable time frame should be that one could wait for 12 hours post a vaginal delivery and maybe 24 hours post a cesarean section to restart heparin after delivery. Now, this is a reasonable time frame, but yes, the Royal College recommends that if there has been no epidural analgesia used, if there has been no PPH, no fresh risk factors, then you can start soon enough, but not before 4 hours post delivery. Keep that in mind as well. And this is the very broad basic discussion of thromboprophylaxis in pregnancy, which I put up for you people in this video. This has been my first attempt for this topic. So if there are any further queries and any further inputs regarding this topic, please feel free to put them on the chat box. I have read up on the Royal College guidelines for this. I've read up on the American College guidelines for this. And these are the sources of references that I have used. What I realize as primary healthcare providers is my take-home message would be that one needs to be aware of the risk factors at every point in time. One needs to be aware that yes, if I am the person in charge, the primary contact person of a woman who is on heparin, at least I should know the very basics that as and when she goes into labor, I should not be the one to, inject her with the dosage of heparin. I should be aware that it needs to be stopped. I should be aware that I should not be starting it within 4 hours post delivery. So keeping those important points in mind, I've curated this video for you people. I hope you liked it, and please put in your suggestions in the chat box. Thank you so much.